Get it over with. Does she right back, huh?
Fluid and electrolyte replacement. I know what it is.
Do you want me to go in there?
Wait on here. Fluid and electrolyte. You realize the body consists of a large amount of water. Without it, your body does not metabolize appropriately. Your cells would die. So we need to maintain that balance. And if you ever not had enough water and got dehydrated, you know that because you start feeling flu-like and lethargic and nauseated because your body's saying, give me water or I'll die. Electrolyte replacement is just as crucial. Those components that are electrolytes are potassium, calcium, sodium, and so forth are important in order for the body to operate correctly. Therefore, we need to maintain those levels as much as possible. Body fluids. We have osmolality. What do you think isomolar is?
Singular.
Going in and out.
Single.
Exactly. Iso is not enough. Well, excuse me. Iso is your homeostasis, your balance. Iso is balance. Hypo is not enough. Hyper is too much. Formula, and we'll see this a little bit later on, but so you have it on, should have it on a couple of slides. If not, I'll make sure that the slides in the blackboard match it. But how we figure out fluids is by 2 times the cerium sodium figure plus the BUN reading divided by 3 plus glucose reading divided by 18 gives you your serum osmolality reading to let you know how much fluid you do need or don't need. Normal is 275 to 295 milliliters. We talk about tonicity, effect fluid on cellular volume. A lot of times osmolality and tonicity are interchangeable. One of the symptoms of excessive fluid causes pulmonary congestion. Why would it do that?
It's a really kind of process.
Say that again.
Fluid buildup.
How, why?
Because you're not able to get it all.
Flushed out.
You're right.
Process
You're
it
right.
that quickly.
It has to come through the system.
Well, it's already in the system. What happens is that the excess fluid will come into the circulatory system so the body can get rid of it. It has to go through the circulatory system to get to the kidneys. So you have too much, now we have too much fluid. The body's not going to pump it appropriately. It builds up primarily in the lungs until we can remedy that. But that is one of the more important symptoms of excessive fluid. Intravenous fluids. The normal range is 240 to 340. That's the number you need to remember. Also 275 to 295 you got to remember. Anything below 240 is hypo, and above 340 is hyper. Classifications of IV fluids. We have these different kinds. We have crystalloids, colloids, lipids, blood and blood products. Crystalloids used for replacement maintenance therapy. We have dextrose or saline, lactate, ringers. These are fluids that help to replace whatever is lost. If you have a lot of blood loss or whatever, this will help to give you replacement if you're lost on fluids, this helps to give replacement without causing any other excessive amount of solute within the solution itself. Replacement and maintenance. Crystalloids we have examples of. A5W means we have 5% sugar in water. 0.45% is the same thing as saying a half normal saline. And then a hypertonic solution is one D10W. Hypertonic is that we were adding more stuff to the fluid itself. So here we are doubling the amount of sugar within the water, increasing the osmolality of it, so we have a hypertonic solution. No, they can be both considered hypertonic.
It don't have no pink. No, it don't have no high
The normal range is 340. Colloids are used as volume expanders. Dextran solution, amino acids, so forth. Let me go back here for a minute. So all we're doing here is volume expanders. How would like amino acids or a heterostart or plasminate, how would that be a volume expander? Explain that to me. Say it. It adds more what to the blood? It adds more bulk. That's a good way to say it. It adds more bulk to the blood. So we're adding components to the blood. How would that make it expand? You say it by one word. Yeah? Osmosis, osmolarity. Osmosis, we add junk to the blood. Now we have too much solute, not enough fluid, correct? So now we pull fluid off the interstitial tissue, goes into the circulatory system, and now we've expanded the volume within the circulatory system. That's what a volume expander does. It expands the circulatory system. Does that make sense?
So you're adding the solute.
Basically. We have blood and blood products. It used to be whole blood with not used very often because of the high rate of allergic reactions, but that's minimal anymore. Even at a high rate, I think the high rate of transfused reactions was somewhere around 5%. Now it's down just above 1%. When you use components of blood, like red blood cells, plasma, and albumin, the chance of a reaction is almost nil. Why would that be? Why would you think that? They are more processed, so what do we processed out? Yeah, your androgens and all the extra stuff that are in the blood, right? Exactly. So we've taken out the antibodies and so forth that the blood has within it. And what happens is that those antibodies and the other components within the whole blood is what causes the allergic response. So when you process it down to red blood cells, plasma, and albumin, you're taking all that stuff out. So now the chance of allergic reaction is down. But again, we are adding an expander, aren't we? Here, with whole blood, we're just adding everything. So you're adding fluid as well as components. The other parts are expanders, and they're used for a variety of different reasons. Either as a blood expander for volume, or to replace what's not there. Lipids are generally used if you have an IV that lasts longer than 5 days. Generally, it's not a hard and fast rule, but generally, because you want to make the person who's on IVs for 5 days, it's probably, other than they're just trying to have a route for a medication or just to replace fluid, generally if it's more than 5 days, the person's not eating. And the only nutrition they're getting is through that IV, so you need to add components which will assist with metabolism and so forth with the body. Give them energy. Questions so far? Electrolytes, sodium, potassium, calcium, magnesium, chloride, and phosphorus, or also known as phosphate, are important electrolytes. If we are lacking or have a decrease in any one of these or an elevation, we can have a problem. The body's not going to function appropriately. Cellular cation just means that it's a positive ion found within the cells. ECF is what? Extracellular. And if you remember, potassium and sodium trade places for the nervous reaction, for muscle responses and so forth. So you have sodium on the outside, potassium on the inside. And then remember, calcium is our catalyst, and it causes the response to happen quicker. Is now the sodium and potassium trade places. And that's what causes that spark. It's kind of like the gasoline in your spark plug. And now your engine runs. Potassium and sodium happening within the cells is what causes the body to operate appropriately and for the cells to live and metabolism to take place. Potassium, normal range, 3.5 to 5.3. In different hospitals with different machinery that may vary somewhat, but not very much. Some books will say 3.5 to 5.0. Some will say 3.5 to 5.2. But it varies with lab calibration. Functions we just talked about. Hypokalemia, anything less than 3.5 milliequivalent. Milliequivalent is a very small amount, not very much at all. Signs and symptoms, not too many. We have oliguria, which is what? What is all? I didn't hear that.
Not urine?
Less than the amount you should.
Thank you. I'm hearing all different kinds of things. I'm just tachycardia, bradycardia, arrhythmias.
Sir,
Man,
I'm kind of taking behind. Can you explain that ECF again?
okay, potassium, sodium. Sodium's an ECF, extracellular
You're trying to
component.
argue in the book that's got ICF.
Well, ECF, ICF. I spell extracellular. They call it interstitial. Interstitial and extracellular are the same thing. The only difference is interstitial means it is between the cells. Extracellular can be in between the cells and within the circulatory system. It's the only difference. But they use interchangeably. Does that make sense? Okay, good. Thanks for bringing that up. Okay. Hyperkalemia. As you can see, muscle weakness, cardiac arrhythmias, metabolic acidosis. The cardiac function, again, is altered. In the early onset of increased potassium or decreased potassium, the symptoms can be very similar. And therefore, a blood test has to be done in order to determine which way we go with it. So correct potassium, a deficit, or excess administration, oral IV. It is never injected directly into the vein. It is always diluted with an IV fluid. And high potassium. We know about fruits, fruit juices, and our friend, the dark green leafy vegetables. Drug effect on potassium balance. Digoxin toxicity causes hyperkalemia. The digoxin, which is what?
A cardiac glycoside.
Thank you. Thank you. What's it used for? Used for dysrhythmia. That's right. Anti-arrhythmia.
Phone working
We
all
have
day.
too much of that. We cause retention of potassium. And then what happens is now the symptoms get worse. Sodium. Normal range 135 to 145.
All these numbers.
As you go through this program, these ranges you will have locked into your head. You need to start remembering them. You'll need them locked into your head. When you're a nurse on the floor, you will be calling them back to remembrance often. To determine the signs and symptoms, you see what are the lab values and where is my patient going? Are they getting worse or better? Or are they staying the same? Hyponatremia. What kind of signs and symptoms are we going to have? What does it do?
Regulate body fluid.
Help to retain water. What's the primary function?
Sodium, potassium.
Conduction. Exactly. So if we don't have enough, we're not going to have conduction. So we're going to have weakness. We're going to have malaise. You will likely have bradycardia, and you could have arrhythmia. Hypernatremia. You have too much sodium. Too much sodium, we have water retention, correct?
Mm-hmm.
And the whole thing where smoke goes, water goes. So now signs and symptoms of too much sodium, you have swelling is the first one. We have tachycardia. We have muscle rigidity. If you think about what the chemical does within the body, how it makes the body work, then the signs and symptoms and side effects pop right into your head. If we know what sodium and potassium, how they exchange places and makes a conduction of impulses, so muscles work and nerves work and so forth, then we can understand what's going to happen based on a lower high concentration of that electrolyte. Does that make sense? Mm-hmm. Don't just think of it in a vacuum, but bring it out, get the broader picture so you can understand exactly what it's doing. Foods high in sodium. French fries. Yes, they are. Salt itself, ham, or one of my favorite foods, Spam. I think that's a favorite meat of Hawaii, isn't it?
Yes.
Spam.
I got it at McDonald's.
I was raised on Spam. In the Army,
They literally do sell it at McDonald's. Over
combat
there.
ration, before they came to the MRE,
And they sell rice.
all it was Spam and eggs. Spam and green eggs. Calcium, 4.5 to 5.6. What does calcium do? Besides bone. It's a catalyst between potassium and sodium. It helps with the nerve conduction. So we know if we don't have enough, we're going to have things like weakness, nausea, vomiting. We're also going to have issues with bone. In a chronic condition, we have bone brittleness. As we see here, fractures, anxiety, irritability, tetany. Lockjaw. Tetany is really easy to describe. It's rigidity of the muscles. Rigidity. If you ever see anybody with tetanus, you'll never forget it. Is that basically when you're lying flat, All that's touching the bed is their head and their heels. And they're arched because the muscles are all tight and they can't release them. It doesn't last very long because they die. Administration, we can give them calcium supplements very easily. Hypercalcemia, clinical management. We need to, clinical management, all we need to do is to manage the calcium imbalance, whether it's high or low. If it's not way out of whack, it may just mean you got to drink some more milk, eat some more cheese, or eat some more green leafy vegetables. And get calcium back into your body. You don't necessarily have to go to the drugstore and buy calcium pills. And effects of different drugs on calcium balance is on table 16.6. I didn't list them all because of the time. No, you will not have to know these. But just get an idea of that a large amount of medication may interfere with calcium absorption. Do not use saline IV. Saline IV tends to assist in the loss of calcium. Just so you know. What's this? Right there on the side. Oh. Well, that's why I said I'll put it in the book. Yes. Magnesium. Magnesium is even a smaller amount. Magnesium operates to retain the relationship of potassium to calcium, so that we have that interaction. We're able to have that exchange of potassium and sodium. Magnesium assists the calcium in order to do that. It requires just a small amount, though, not very much. All we do for this is to give them magnesium, and we have alleviated the problem. Magnesium continued, as you can see. What do you think foods high in magnesium are? Fish. What else?
Green vegetables.
Dark green leafy vegetables. Thank you very much. It is, yes. And again, the effects of drugs on magnesium are found in that same 16.6. Chloride. Normal ranges. What does chloride primarily do? It binds to sodium. And then what does it do? It precipitates out.
He said define the sodium.
Precipitates out. The function of this, not only to bind with sodium, but also binds with hydrogens in order to make acid. That's where you get your stomach acid. It's not magic. It comes from hydrogens and chloride. That's why they call it hydrochloric acid. Pretty neat, huh? If you have too much, you have acidity. Too less, you have alkalinity. That's all. I'll go into that. Phosphorus. What's your highest food in phosphorus? It is not dark green leafy vegetables, by the way. Actually, it is. I just want to tell you now. It is. Whole grain cereal, meat, meat products, hot dogs. Meat product.
Fused parts.
We have a key component of this called phosphoric acid, which is a combination of phosphorus and hydrogens. I don't think it has chloride, but anyway, phosphorus and hydrogen. Where do you find that? Phosphoric acid.
Protein.
Soda. Soda is one of the primary ingredients in soda is phosphoric acid. What does it do? It takes the enamel off your teeth. It also causes calcium to leach from your bones. It causes osteoporosis. Pardon? In a small amount, it operates with an enzyme. But the laundry soap uses phosphorus rather than phosphoric acid. They use phosphate. And that reacts with an enzyme to get the dirt out of your clothes. We'll skip that one and go right to this one. Nutritional support. We have enteric nutrition. The routes of the enteral is through nasogastric tube, through the mouth, through the stomach tube, or through what's called nasogastomy tube. Or we have one that could go down into the duodenum, past the stomach, one that goes down into the jejunum, past the duodenum and the duodenum, between the duodenum and the enteric solutions are blenderized, milk-based products which you can eat and give you the nutrition that you need. Most of you have no idea about Vasomatic, but that was a big thing back in 1976.
Is that you?
And the suit. Yeah, the suit, 1970s. Never mind. Anyway. Method of delivery is bolus. That's how you guys swallow, by the way.
Yeah.
You chew and you swallow and you hunk a swallow down. That's a bolus, by the way. Some people just swallow more bolus than another, but that's what that is. So we have that in a tube feeding situation. That is nothing more than a measured amount within a syringe. It's pushed into the stomach. That's a bolus. We have infusion. We have intermittent drip, where it'll drip for so many hours and then it will be off. We have some that are continuous, that they drip 24 hours a day, and we have cyclic infusion where they may get for 2 hours and they're off for 2 hours and they're back on for 2 hours, off for 2 hours, and so on and so forth. Different ways to put them into the person. Complications, the primary complication is aspiration. The head of the bed should be kept at 45 degrees. The book says 30 to 45, but remember it's 45. That's important. Complications from this is diarrhea. This stuff is already partially metabolized, so it just comes into the stomach. The stomach has to just mess with it, and it goes into the intestine and that's absorbed. Because of the how it is laid out, a person gets diarrhea fairly easy with this. And then a hold of continual infusion for 1 hour if you're greater than 50 milliliters of residual. Residual is before you give the feeding, you actually check your placement of your tube by pushing air into it and listening for the air within the stomach. And then you pull back to see how much stuff comes out. Is there stuff left in there or not? There's always somewhere less than 50 cc's that stays in the stomach.